welcome to On the Horizon, a discussion about emerging therapies. I hope everyone is enjoying Symposium. For those of you who have attended this a few times, you know that we often do the presentation separate from the questions and answers so that you have a little bit of time to think about your questions. But that doesn't mean you can't ask questions tonight. We will answer them on Friday. So go ahead and you can use the Q&A function, or you can use the chat function to put your questions in, and we'll capture all of those and answer them at our session Friday, 8 p.m. Eastern time in 2 days. We have a wonderful panel. Some of you guys have probably seen a few of these folks already present. They're so bright and brilliant and amazing. We have Dr. Allison Wheeler, Dr. Robert Sidonio, Dr. David Clark, and Dr. Lisa Hensley. So without further ado, I'm going to turn this over to Dr. Wheeler, and she's going to moderate us through the session. I'll see you guys at the end. Thanks for coming.
Okay. Hi, everybody. As Lori said, I'm Allison Wheeler, and I'm going to be talking to you about bleeding disorder therapies, specifically factor replacement and current bleeding disorder therapies. I know we're talking about emerging therapies mostly tonight, but I wanted to just do a quick review of sort of what came before. So if you could actually just click next slide, that was just, I just want to, oh, you or me?
Yeah, let me go ahead and thank our sponsors. Without them, this wouldn't happen. And there they are.
Wonderful. And then, as I said a moment ago, I'm Allison Wheeler. I'm going to be talking about factor replacement therapy. Next slide. These are my disclosures, and you can just keep going. Next slide. So I've really become accustomed to showing a slide, either this one or a slide I like this one because I think it's so exciting and really important that we look at the timeline of hemophilia therapy whenever we're talking about either current or new therapies. As you guys can see from this slide, over the last 30-ish years, it's just been an explosion of products that have come onto the market. Starting with the concentrated products in green, moving then into the recombinant era in blue, subsequently our long-acting recombinant products in orange, and then finally our first commercially available product that's a non-factor product for hemophilia, Hemlibra in red. It's been really, really impressive, and I think the number of commercially available products has just expanded and given so many options to people. As you guys can see, that one very small but very important column on the right side of the screen, the gray box, is those new products that are coming through the clinical trial pipeline. And my co-panelists are going to talk about those in much greater extent. But beforehand, we're just going to talk about what's available now a little bit. So next slide, Lori. So this slide is super jam-packed and really just shows all of either the plasma-derived or standard HalfLife products that are available today. And we put these all on one slide because despite the fact that there are some differences, and I'll talk about those really briefly, these products all are so individual, and choosing one over the other for a large group of patients is really not something that we generally do. Rather, an individual patient might prefer an individual product for them, but it's hard to sort of make more general sweeping comments. The few differences that I do want to bring up, sort of comparing the left column, the plasma-derived products, and the right column, is I think everyone's probably familiar with the CIPIT data, the randomized trial that asked and answered the question about the use of plasma-derived products versus recombinant products in previously untreated patients, and the benefit of plasma-derived products for patients with severe factor VIII deficiency in terms of inhibitor development. We could talk for this whole hour about CIPIT, but we're not going to do that, but just sort of throwing out there that is one distinction. We also do see in a lot of patients a subtle yet sometimes really clinically important extension of half-life in those plasma-derived products. but we also see a great safety profile in some other realms in those recombinant products, and I use them very regularly in a lot of my patients. So lots of products on the screen, not lots of huge differences for groups, but small differences or big differences for individual people. Going on to the next slide, we wanted to just touch base on those extended half-life products a little bit. And you can see the factor 8 and factor 9 products that have all undergone bioengineering, excluding the Afstyla product. And that bioengineering is aimed at extending the half-life of those products. And in the right-hand column, you can see what those modifications are, just sort of listing them out for you. But I want to go on to the next slide. This next slide, that focusing on factor 9 just sort of depicts a little bit about what those half-life extensions are. And so you can see sort of the base recombinant factor 9 molecule in the top there, and then the 3 modifications that we see, the addition of the Fc receptor, the addition of albumin, and then the addition of a pegylated molecule. And so when we think about that half-life extension, each of those modifications can create sort of either, in the case of the Fc fusion molecule, decreased lysosomal degradation of the factor product, and then the albumin and the PEG just delayed degradation of those proteins, and really results in a significant extension of the half-life. You can see that a little bit numerically in the next slide. And what this slide is showing us is those pivotal trials that demonstrated the extension changes in half-life, and then in association with that, ability to sort of extend the time between prophylactic doses in patients receiving these factor 9 products. I think most of the people in this talk probably are aware that factor 8 doesn't have quite the extension yet that factor 9 does. But Dr. Stonio is going to speak a little bit more about some of the nice innovation that's happening there. One of the things that I wanted to sort of point out on this slide is that you can see those half-life extensions and those PK profiles of those different molecules, those different factor 9 molecules. And I think the important thing to sort of just note in this is that even though we have longer half-life extension, there are definitely people who prefer those shorter half-life products. They feel that they get more of a hemostatic benefit from them, even though their troughs are sort of lingering lower than they could be with another product. And so even with these bioengineered products, these modified products, I think it's really important for all of us to remember that an individual product can sometimes be better for an individual patient. And while half-life extension is really important and really wonderful, it has not been an exact science for all of our patients. And then just moving on to this next slide, just to sort of numerically see these half-lives here so that people can sort of appreciate the numbers. I'm not going to belabor this too much, but you can see sort of the extension in the plasma-derived products that I mentioned, as well as those extended half-life modifications. And then that final row on the bottom, just sort of pointing out the half-life of Hemlibra for patients with factor 8 deficiency. So switching to another topic, I just wanted to talk briefly about inhibitor treatment options and ancillary products for patients who do have inhibitors. Next slide, Lori. You can see here, this list is much shorter, unfortunately, although some of our innovation is hopefully tackling this. But for both hemophilia A and B patients, FIBA is a concentrated product that can be used in either group of patients. And then Novo7 is Epticog Alpha. And then fairly new to the market is 7-Fact Epticog Beta. I will fully admit that when I first saw 7-Fact come onto the market, I said, why? But that difference between the alpha and the beta molecules is something that I think is worth paying attention to, especially for individual patients. Some of the 7-Fact data, and only available for patients greater than 12 by the FDA right now. Some of the 7-Fact data does show some response with single doses or improved response in certain patients. And so not thinking of those products, especially for an individual, as exactly equal is something that I have chosen to do. And I think is something that a lot of people are thinking about. And then obviously for hemophilia A, we have Hemlibra, which is just a very, very different molecule that we're not going to go into in detail. And then finally, for patients with acquired hemophilia, so inhibitors from that direction, Obizur is a molecule that we can utilize in that patient population. A little different than most of the other stuff we're working on. And then finally, additional therapies to consider, the adjunct therapies. We have the first three rows here are our anti-fibrolytic medications, so medicines that are going to strengthen and stabilize blood clots and improve bleeding symptoms, used a lot more in patients with mucosal bleeding, but can be utilized in other circumstances depending on the clinical details. And then finally, DDAVP, which I think we all have sort of been hit with the nasal DDAVP formulation Stymate being recalled last summer, but it is still available in either subcutaneous or intravenous form and can be utilized in patients with mild hemophilia or mild to moderate von Willebrand if patients, both clinically and often from a laboratory perspective, respond to those medicines. So with that, I'm going to conclude my data portion of the discussion, and we'll just shift to Dr. Sidonio to begin our discussion of emerging therapies.
Thank you, Dr. Wheeler. I'll take it from there. So we're going to talk a little bit about rare bleeding disorders. We talk about factor replacement. We don't think that is an old-fashioned thing. It's something that still will exist in the future when we do this talk 10 years from now. And then we'll talk a little bit about bispecific antibodies and then talk some bypassing agents before I pass it on to Dr. Clark, who will talk a little bit about the rebalancing ones. Next slide, please. So these are my disclosures. All right, so let's talk about the rare bleeding disorders. And we'll get to Coagudex a little bit later. But just as a reminder, if you have fibrinogen deficiency, there are available products, both from Octapharma and CSL Behring and Fibriga and Riastap. These are both products that work very well for replacements. They're not indicated for dysfibrinogenemia on label. And certainly at times we may consider using cryoprecipitate. But the preference is generally if there's a factor concentrate available, you should use it, unless there's an issue with reactions and such. And it's good to note, Dr. Wheeler talked about 7-Fact, although it is available and indicated for use for hemophilia patients with inhibitors, it does not have the indication for factor 7 deficiency, and Novo 7 has that indication. And we have a number of patients that are receiving that on prophylaxis. And not to be left out, factor 13 deficiency, although extremely rare disorder, most centers do not have more than 1 or 2 patients from different families. But certainly there are 2 products that are available. I've utilized both of them. They both work very, very well. Corifact and Tretin. Tretin made by CSL and Novo Nordisk. And of course you can use cryoprecipitate as needed. And then we'll talk a little bit about Coagudex in future slides. Next slide. So going back to this slide, certainly there's been a lot of excitement over the last couple of years, Hemlibra, ushering in the age of the quote unquote bypassing agent or non-factor therapy or whatever people are calling it. But certainly in the next 10 years, we always tell our patients what product you're on now is probably what you're not going to be on that same product in 10 years. And certainly gene therapy will be a discussion point next year when likely one of the products will be available, and hopefully in 2023, a few more will follow next. So just as a reminder, when we talk about R&D, we're still talking about discovery, process development. There are a lot of products that don't make it past this portion. And certainly a lot of products don't make it past the preclinical. When we say preclinical, that typically means animal. We're talking about some early animal study, late animal studies, and some discussions in use in humans. And then certainly we talk about phase 1 studies. We're looking really at safety, tolerability. Phase 2 studies, we're looking at the dose that may work with efficacy. And oftentimes, sometimes the phase 1 and 2 studies are combined. And phase 3 studies, really, that's what we're utilizing to get the label indication. Whatever dose is decided on, that is what typically ends up on the label. And that's when you really want to demonstrate that it works in a large, diverse population. And then, not to be outdone after that, it's really important that you pay attention to those phase 4 studies. Sometimes the phase 3 studies are very limited in their scope. They don't answer all the questions. And the phase 4 studies may help answer some questions, particularly in distinct populations that may have been left out. Next slide, please. So just as a reminder, we talked about the improvements that you have seen in factor 9 products. When it comes to the extended half-life products, we're talking about 4- and 5-fold extension. And although they are improvement and there are a lot of patients that have benefited, we know that VWF has been the glass ceiling. And the uncoupling of it is probably the only thing that's going to allow us to have a significant prolonged extension. And of course, Hemlibra's half-life is approximately 28 days, which allows it to be dosed infrequently, and allows oftentimes for, if you miss a dose by a day or two, it's not going to have any clinical effect. Next slide, please. So the first product we're going to talk about, we're mostly focusing on this product because it is very far along. It's currently in the phase 3 trial. So they're hoping to enroll patients in this study to hopefully be able to be approved in a few years. It's an intravenous drug. Initially, there was some question about whether it could be given sub-Q, but they've decided to pursue that intravenous only route. And it is under phase 3 development. Next slide. What's really exciting, and just as a reminder, if you look at the products and the technology, drugs like Eloctate are using the FC portion of the IgG molecule to extend the half-life. You can also pegylate it, such as been done in NHEP or Esperact, or depending on if it's site-specific or not. Similar in Adinavate, which should be completing its PUP studies soon. And then Jivi, as many of you know, is a different version, but the same technology of using glycol to extend the half-life. And you can see generally the half-lives are all about the same and slightly longer than the extended the previous generation. What one thing was looking at is that VWF has its dance partner, which is factor 8, and it often protects it from premature degradation, but it also limits our ability to extend that half-life. And you can see the specific location in which it's bound at D', D3 domain. Next slide. So what Sanofi has done is they've taken their parent molecule, the single chain factor 8 FC, and to keep it from binding to endogenous VWF, they took a very small portion of a VWF molecule to stabilize it. You can see here, it looks like a D comma, it's a D', D3 domain. And then they've added these things called X10 linkers. And these have really been created in an effort to be an alternative to the polyethylene glycol or the PEG molecules. And they were recently created in an effort to do this. These are protein-based polymers, and they sort of mimic the properties of PEG. The purpose is potentially it's more biodegradable, but certainly we haven't seen any issues in older patients with PEG. So advance slide, please. What you can see here is that once thrombin activates it, you can see the little cartoonish scissors there. It removes the VWF molecule and the X10 molecule. Advance, please. And what you're left over with is the factor 8 FC molecule, which should continue to participate in hemostasis. There is a potential theoretical concern that if you remove the interaction from VWF, that maybe it won't co-localize to the site. They have not seen that, but it's a theoretical concern. Next. You can see here the extension from a typical factor 8 half-life of about 8 hours to an FC of 16.5 to BIB001 of 32 hours. And the studies have shown that you could have levels as high as 40% at 5 days and 18% at 7 days. So certainly mimicking what we are seeing in the factor 9 extended half-life molecules. Next. So not to be outdone, we've talked about the extended half-life products. These are all good probable. So let's talk a little bit about a few. I'll start first with the factor 9 FP sub-Q made by CSL Behring. That's very early in development, and I don't have any data to show today. Similar to the BIV002, it's been mentioned previously, but very, very little data has been released, and so I'm not privy to any of that information. But certainly using the X10 to extend the half-life further, and of course, potentially exciting with the sub-Q drug from CSL Behring. But what we will talk about is a drug that is further along in phase 2, entering phase 3. It's dalsanomicog, or Dalsa, made by Catalyst. And the excitement is it'll be a sub-Q drug. Next, please. So this drug potentially could have approximately 20-fold increased potency over wild-type factor 9. There are multiple mutations that have been created to improve the hemostasis by resisting it to antithrombin, increasing its ability to bind to factor 8, and the procoagulant activity as well to factor 10A. And this is a subcutaneous product. Data was just released not too long ago. Next slide. What you can see here, advance please, is that a phase 1/2 trial in severe hemophilia B has been completed. Next. And the troughs they've been able to achieve are approximately over 10 to 15%. Next, please. It is notable that there were 2 cousins that shared similar HLA type and genotype that developed anti-drug antibodies, which are different than inhibitors, and they didn't cross-react with native factor 9, so those patients were able to respond to factor 9. Next, please. One was non-neutralizing and not clinically significant. Next. And one was neutralizing. Next. The phase 2 trial is initiated. Next, please. And 6 patients were dosed subcutaneously for 28 days. Next, please. And had the same HLA and genotype. Next. One thing that they did take a look at is they did something called in silico analysis, where you can do computer modeling. And they demonstrated that the immunogenicity risk is probably about the same as a factor 9 molecule. The concern always is that when you try to inject something subcutaneous in the body, your body has a natural developing antibodies. That's why vaccines work. The most interesting part of this is, so there are multiple cohorts here, and I'm not going to go through all this just for the sake of time. But if you look at 2 of the cohorts at the top, they actually infused intravenous and then gave doses subcutaneously afterwards. And you notice that they were able to sustain those levels fairly high. You have to look at the scale on the left-hand side, because it's the highest scale is only 40%. But what that actually shows is that saturating those collagen type 4 receptors with a larger dose may actually improve subsequent dosing afterwards. But the excitement of daily dosing and able to achieve over 10% troughs is quite exciting for this product. Next, please. Advance, please. And so, you can see here, again, additional data showing on day 29, the mean levels are approximately 19.4%. So very exciting, as low as 13 and as high as 24%. The half-life is somewhere between 60 to 122 hours. When you only have a small number of patients, there isn't, the tightness of that is not very well determined. There was a non-neutralizing antibody that really didn't have any clinical effect. No breakthrough bleeds during the dosing or washout. And you can see the exciting levels here, similar to what you're seeing in the gene therapy trials. And so, it may not be for everybody, but this is very exciting to be able to dose with a subcutaneous 9. So more data to come, hopefully presenting at the next meeting. Next, please. Not to be outdone, we talked about how there are additional products. You can see here, Benefix on the left side are the native wild type factor 9. Similar could be Ixinity as well. But you can see building on that, they've added FC molecules to make all Prolix, and then looking at attempting to enhance the activity with the Padua variant, and also adding X10 molecules or these protein-based polymers that biodegrade to extend the half-life. So hopefully some excitement to hear about this. Hopefully we hear more about the CSL product in the future as well. Next, please. So not to be outdone, we learned a lot about bispecific antibodies over the last few years. And we all know about emicizumab or Hemlibra, and we're not going to talk about that. But everybody had to know that that wasn't going to be the only drug on the market. So Novo Nordisk, they're pronouncing it Mimate. I think it looks like Mimate, but we'll go with Mimate. It's currently in phase 2 trials. It is delivered subcutaneously. And then not to be outdone, that their second generation from Hemlibra, or Next 007, is being worked on currently by Roche, and will also be subcutaneous with some modifications that hopefully will improve the efficacy of some of the minor gaps in the current product. Next, please. So let's talk a little bit about Mimate, since it is available, and it is undergoing clinical trials right now in phase 3. It's reportedly will have an enhanced activity over emicizumab, potentially up to 15 to 18 fold. And what it looks like is the improved activity is in the factor 9A arm, or the stimulatory activity. And you can see here what the theory is that what they're trying to do in A listed here is that they're trying to minimize the reactions in solution or in circulation and maximize reactions at the site of injury. So we'll have to see if this bears out in clinical studies, but certainly this is exciting. And, we always draw these little cartoon Ys, but you can see on the right-hand side, it sort of looks like that. It's similar to that. But you can see how it brings 9A and 10 together, activating that on a platelet surface. So very exciting to have additional products on the market for the community. Next, please. You can see here, they've optimized the stimulation of the 9A proteolytic activity in the 9A arm, and they optimized the affinity to factor 10 to try to avoid those interactions in circulation, maximize the interactions on site. So next, please. Well done. Factor 7, I wish I could show you this one of the timelines I had. I couldn't find it, but it highlighted all of the failures in the factor 7 products over time. So it isn't for a lack of trying. The companies have been trying this for a long time, and they're still trying to come up with this. The one that's made it the furthest, and particularly is very exciting, is by Catalyst. It's undergoing phase 3 trials. It's a sub-Q product, and it's called Marzeptocog Alpha. Let's talk about that in the next slide. So it is a novel sub-Q 7A product. It's predicted to be about 9 times more potent compared to the current 7A products. The catalytic activity has been increased. You can see here where the modifications have been to increase the procoagulant activity. And most importantly, the half-life has been at least tripled, which has been a very big limitation to the current product. Obviously, the phase 1 and 2 trials, the complete trials are currently underway. Next slide, please. You can see the schema here. They're going to enroll approximately 60 patients. This is going to be a study of patients that are on demand, 12 and older. Typically, most of the adult and adolescent studies start at age 12. They'll be randomized to receive at least sub-Q Marzeptocog, wash out, and then get the standard of care on this as well. And they're going to follow this over time, standard of care being a typical factor 7A product. And so we'll see. Hopefully there'll be enough bleeding events. I think that it will definitely happen when you're talking about on-demand patients with hemophilia and inhibitors. And so stay tuned for this study. So really exciting study. Next, please. And then finally, I think the last products we're talking about, not to be outdone, 10 is another daunting target that a lot of companies and institutions are targeting. And we're going to talk about the one that actually has made it through on the next slide. So Coagulation is a plasma-derived factor 10 concentrate, and it's indicated in adults and children with congenital factor 10 deficiency. So it's indicated for routine prophylaxis, for on-demand, and for perioperative treatment. So they've been able to undergo all those studies needed in the phase 3 trials to get those indications from the FDA. And if many of you remember, if you had factor 10 deficiency, you had to get a prothrombin complex concentrate. The problem with that is that you got a lot of stuff you didn't need. And as you can see here in the chart here, and there's nothing wrong with these products, but you don't want, it's very unpredictable on how much factor 10 you got. You dosed it based on factor 9, and it wasn't always clear how much factor 10 you were going to get. And so that made it very challenging and a little scary when we did surgeries. And so we're really happy that Coagudex is available for our factor 10 deficiency patients. Next, please. Now I'm going to hand it off to Dr. Clark, and thank you very much. And please do stay tuned on Friday for the questions.
Hi, everybody. I'm Dave Clark, and I'm going to be talking to you about rebalancing agents and a few other ancillary products. Next slide, please. I have nothing to disclose. Next slide, please. Now, this is a drawing of the coagulation cascade. And the only thing I really want you to take away from this is that it's very complicated. And in fact, this is a simplified version. And there are even a number of proteins that are not included in here. Plus, we keep learning more and more about the clotting system all the time, and find more little connections along in here. But what we're trying to do with these rebalancing products is that if you're a person that does not have a bleeding disorder, this clotting cascade is kind of in balance, so that your blood clots when it needs to and doesn't clot when it shouldn't. When you have hemophilia and you knock out an important part of this, which is either factor 8 or factor 9, you sort of upset the balance in this. This system is a whole series of both clotting factors and anticoagulants. The clotting factors are the ones that cause the clots. The anticoagulants are the ones that control the system. A lot of people call them the brakes on the system. If you didn't have the anticoagulants, once you got this process started, you would just keep clotting until all the blood in your body was clotted. So the anticoagulants are very important in keeping things in balance. But if you've lost part of the balance because you've lost part of the clotting side of it, then one of the ideas is that we can then reduce some of the anti-clotting or anticoagulant activity in order to kind of restore the balance, so that again, your blood would clot when it needed to, and it wouldn't clot when it didn't need to. So let's go to the next slide, please. There have been a lot of different suggestions about what to call these products. I started out calling them alternative coagulation pathways because we were kind of tweaking the clotting system and trying to find ways to adjust it. But I was never really satisfied with that. A lot of people call them non-factor therapies, but that's really too broad a category, because there are other products that aren't rebalancing agents that are under development to treat hemophilia. We could call them anticoagulant inhibitors, and that's what most of them are. But we may find other ways of tweaking the clotting system to restore the balance. So people have seemed to be kind of settling on the name rebalancing agents. I've seen this more and more in the medical literature, and it's accurate and descriptive, so I've started to use that. So let's go to the next slide, please. One of the important anticoagulants is called tissue factor pathway inhibitor. And so the tissue factor pathway is the pathway that gets clotting started very quickly when you first have an injury. And it involves factor 7. That's why you use factor 7 if you have an inhibitor, to sort of trigger this pathway, even if you don't have factor 8 or factor 9. And so a number of companies have decided to focus on tissue factor pathway inhibitor, which we call TFPI, to basically inhibit the inhibitor, to inhibit the anticoagulant activity of the TFPI. And so in that way, restoring some of the balance and allow clotting to happen more easily. So you can see that there are a number of companies working on this. Novo and Pfizer are probably the farthest ahead with their products, which are subcutaneous products, which are going to be much easier to use than an intravenous injection that you all use now. GC Pharma is a South Korean company that's starting out in phase 1 with their product. And then Takeda is also working on this, but they're only in the R&D stage. Now, for some reason, everybody seems to have focused on TFPI. In fact, there are a few companies that have already dropped out of this race for various reasons. Bayer, for instance, was working on a product, and they made a business decision that they could spend their resources better on something else. One of the things I want to point out on these rebalancing agents is that they will work for both hemophilia A and hemophilia B. Since they don't involve the clotting factors, either factor 8 or factor 9, they're just tweaking the clotting system. So if that factor 8 and factor 9 part of the process is missing, because you're missing either one of those factors, these will still work. The other thing is that they potentially will work on patients with inhibitors. And in fact, both of the first two, concizumab and marstacimab, are being tested on inhibitor patients. And again, because they don't involve factor 8 or factor 9, the inhibitor has nothing to inhibit. So these will work for that. So potentially these are going to be a great advance for hemophilia treatment in general. I mean, we'll see if this all works out. The big problem that everybody has been facing in this is that what happens if you have a breakthrough bleed when you're on one of these? Can you treat it with factor or an inhibitor patient? Can you treat it with a bypassing agent like Novo-7? So far, there have been different results on this. And it turns out you just have to be very careful when you start messing around with the control systems in the clotting process. You really got to be careful because things can get out of hand. So they're finding that, yes, they can treat breakthrough bleeds with factor, but you have to be careful about how much you need, about how much you use, or with a bypassing agent, you have to be careful with how much you use, because you can easily shift the balance all the way over into thrombosis. Thrombosis is unwanted clotting, and which can be very dangerous or even deadly. So let's go on to the next slide, please. Not everybody's working on TFPI, that there are a number of anticoagulants that we can target. And we don't, at this point, we don't really know what is the best one to target. And again, this is all going to be very experimental. We don't really know what is the best anticoagulant to target, or maybe a mixture of them, or just what. So this is all, oh, okay. Well, before this, I'm going to start with, I want to talk a little bit about concizumab. I forgot this slide comes next. So we see the FP there, and it, one of the things that gets clotting started is tissue factor, which is a protein that's found on the inside of the cells that line the blood vessels. And so normally, because it's on the inside of those cells, the bloodstream doesn't really see that. So the bloodstream just keeps flowing along like normal. But when you have an injury and break open one of those blood vessels, you expose the tissue factor, and that starts the clotting process. So tissue factor works with factor 7, factor 7A to get the clotting started. And you can see the TFPI we're showing here inhibits that reaction. And it also inhibits factor 10A, which is farther down in the clotting process. So if we can, next slide, please, Lori. So if we can use monoclonal antibodies, which are man-made antibodies to target TFPI, they'll basically attach themselves bind to the TF protein and block it from being able to inhibit the tissue factor 7A process or the factor 10A. And then the graphs here, I'm not going to go into a lot of detail, but let's just look at the one for hemophilia B to start with. On the vertical axis, the up and down axis, you see it's called peak thrombin. Thrombin is one of the final enzymes. In fact, it is the final enzyme in the clotting process. So the more thrombin that you can generate, the more clot you can generate. Thrombin converts fibrinogen to fibrin, and fibrin is a sticky protein that sticks together to form the actual clot. And so you see, they're looking at different concizumab concentrations along the bottom axis. And you can see as you go along for a little while at first, there's not much happening. But then all of a sudden, when you get to the right concizumab concentration, you start seeing an increase in thrombin, which translates into an increase in clotting. And then as you go up, it kind of levels off after a while, and probably when you basically neutralized all the TFPI, and then things are just going on the way they go. So let's go to the next slide, please. Okay, here's the other rebalancing agents. I want to especially talk about the first one, and I'll talk about a little bit about that on the next slide. But that's in phase 3 studies. Fitusiran was initially being developed by a small company called Alnylam, and now it's been taken over by Sanofi. And they're getting very good results from that. And then you can see that the next two inhibit both inhibit activated protein C. Those are two other anticoagulants. Protein S is another anticoagulant. Protein Z dependent protease inhibitor is another anticoagulant. And then finally, at the bottom, we have a new product from Band Therapeutics that we don't know much about, but that seems that it will work with non-severe hemophilia and VWD, and basically target one will cause it to have more activity and to probably release more factor 8. So let's go on to the next slide, please. Okay, here's Fitusiran. I think this, if they get this worked out right, this could be a very interesting product. On the bullet points on the left there, you see down about the third one down, they discovered this idea by seeing that in some people with hemophilia who also have deficiencies in antithrombin, that they have a milder bleeding phenotype. In a way, they're naturally coming up with a more rebalanced or more balanced clotting system. So the idea here is to inhibit the antithrombin. And you see on the diagram at the left, antithrombin inhibits thrombin, as you would guess from its name. It also inhibits factor 10A, which is part of the pathway to making thrombin. Now the unique thing here is this is not something that inhibits antithrombin directly, like the antibodies that we saw for TFPI. This one actually keeps antithrombin from being made. It's called RNA interference, and it basically interferes with the body's process for making antithrombin, so that the body will naturally quit making as much antithrombin. Now, Fitusiran got into a little bit of trouble recently. It turns out they had really brought their antithrombin levels too far down, so that they were seeing thrombosis, too much clotting. But now they've readjusted their doses, and they're getting their clinical trials started again. And so we'll see. This may turn out to be a good product, but again, we just have to wait and see what all the results are. All of this is kind of trial and error, just trying to find out what the best anticoagulant to inhibit is, and how to do it in the best way. Our state of scientific knowledge isn't enough that we can just look at all these reactions and say, yeah, this is the one we want to hit. This is a somewhat trial and error, but that's how, when you don't know a lot, that's part of how you develop these things. Well, next slide, please. Okay, now I want to talk about rofecoxib. I'm calling this a resurrected pain reliever. A lot of you older patients may have used Vioxx in the past to treat joint pain. And unfortunately, Vioxx was taken off the market. It was a very highly used general pain reliever. And it was taken off the market several years ago when it seemed like it was causing cardiovascular problems, heart disease problems. But a lot of hemophilia patients found that it really did a great job, actually much better than opioids, for reducing their joint pain. So this company Trimo is trying to bring it back, and they think they can do it safely with in a much more controlled way, using it in a much more controlled way for hemophilia joint pain. And you can see under the administration route there's just an oral pill that you would take. And they're in phase 3 studies now. So we'll see whether this comes back. I have a feeling that the cardiovascular problems came from people overusing the Vioxx. People that have a lot of pain and their users tend to overdo it somewhat. And I have a feeling that may have led to some of the cardiovascular problems, which you could get with even overusing aspirin or anything like that. The other thing about this, as opposed to some of the other similar products like it is, it has very minimal gastrointestinal issues. So it's, in a sense, much more comfortable to use. And then finally, let's go to the next slide. These are interesting. These are 2 clotting analyzers, basically just portable instruments that can measure how easily your blood clots. Right now, you know that if you go to the doctor, he usually takes a blood sample and has to send it off to a lab. But both of these are things that he could have right in his office to measure the clotability of your blood right there. And in fact, the NZ-Pad, the second one, they're even looking at this as a possible product for home testing. It interfaces with a smartphone. Basically, at home, when you're trying to figure out if you need a factor infusion or something, you could check your clotability and just decide how much to use. So both of these could be very interesting products. And we'll see, as they come along. Both of them just take, either a finger stick or a blood drop, which is essentially the similar kinds of thing. You just draw a little bit of blood from your finger, just like a diabetic person would do to test their insulin. And so, we'll see what happens with these. And I think this is my last slide. So go on to the next, Lori. Yes, and so I'm going to give way here to Dr. Hensley, who's going to tell you about gene therapy. Thank you all.
Good evening. Thank you all for staying with us. Can I have the next slide? It's always difficult to follow such wonderful speakers. I have nothing to disclose. Can I have the next slide? I should mention, though, however, I am here in an unofficial capacity. My background is in epidemiology and in virology. But perhaps more importantly, I should mention that I'm the daughter of a hemophiliac. I also have a son who's a hemophiliac. And probably my choice to go into science was really driven by watching the struggles that my father had gone through and watching the challenges of finding treatments and finding safe treatments. And, we're here, we've really watched our speakers take us through this journey, through this timeline. And as we've come closer to the end of this timeline, we've really witnessed this incredible scientific revolution that we've seen in the advent of so many new therapies that are coming to the market and different technologies that are coming to bear. And one of those is, of course, gene therapy. And we're starting to see gene therapy come to the marketplace and be used for treatment of multiple different indications. And I'm going to talk a little bit about how we're starting to see gene therapy being evaluated for treatment of hemophilia. Can I have the next slide, please? So what is gene therapy? And I know we have a diverse audience here tonight, so I'm going to apologize. Some of you know this so well and perhaps even better than I do, but I think it's always important that we go through this. So gene therapy is the introduction or alteration of genetic material within a cell or organism with the intention of curing or treating a disease. So I do want to be very clear that where we're at, that sometimes it may not be curing, sometimes it may be moderating or minimizing a disease state. So here tonight, we're going to talk about two types of gene therapy that have made it to clinical trials for hemophilia A and B so far. And both have used what's called an adeno-associated virus. And they use the adeno-associated virus as a vector or a vehicle to deliver the gene therapy. So you're going to hear AAVs a lot. So AAVs are probably the most common type of vector that's used for gene therapy that is out there. And AAVs are being used for a couple of different reasons. So AAVs are a virus that were discovered probably around 1960 in the laboratory. They were discovered by accident. So they are not believed to cause disease, so meaning that they're not pathogenic. And our bodies don't make a lot of an immune response. So they're considered to be non-immunogenic. So they're small viruses and they're easy to manipulate. So people have been using these AAVs to package genes and to deliver them. This is why they're called a vehicle. In order to get the gene to the right cells, it needs to be protected. So this is why we call them vehicles. So when we talk about gene therapy, it's important to groups. So you're going to hear this quite a bit. You're going to hear something that's called gene transfer. And this refers to the delivery of a new genetic code that can be used to provide a functional version of that gene. And then you're also going to hear what's referred to as gene editing. And gene editing is an important distinction. This is the delivery of tools that correct, disable, remove, or modify the DNA of a cell permanently. Can I have the next slide, please? So how does gene transfer work? So gene transfer uses, again, a neutralized version of the AAV, so an adeno-associated virus, to deliver a functional version of a mutated gene. So what does a neutralized version mean? This means a non-replicating one. It means that this vector, once it gets into your body, it's not going to continue to replicate. So what happens? So how is this done? What occurs? So the viral DNA is removed. So the viral DNA, the DNA that's normally in this virus, is removed. The functional DNA is inserted into the shell of this virus. This is what's actually creating the quote unquote viral vector. We then take that viral vector and we infuse it into the patient. So remember that shell, that viral envelope, that viral coating is what's being used to protect that DNA and what's being used to deliver it. So once we infuse that viral vector helps target to the right organ. And in this case, it's the liver. And once it's there, the viral vector helps to unpack into the right cells. It delivers it, and the functional DNA is loaded into the cell nuclei, where then it provides the code to the liver cells. And then it's allowed to be, your cells then start to produce the right clotting factor. Can I have the next slide, please? So how does gene editing work? So gene editing is a little bit different. And I think this is where people start to get a little bit nervous. So when you start talking about gene editing, you're starting to talking about changing DNA. And this is where I think many people start to get a little bit more uncomfortable. Where you're talking about the other one, you're talking about delivering a copy of a gene that sits there and that is being used to make a new protein, a corrected protein, or a correct version of a protein. So with gene editing inserts a mix of tools that will edit the DNA in vivo to allow the body to produce the clotting factor. So here, the viral DNA is removed again from that vector. So again, we're taking out the DNA that was originally there, and we're putting in a mix of tools. So we are putting in enzymes that are referred to as engineered nucleases. And then we're also inserting these into the remaining shell. and we're creating this viral vector. The viral vectors are then infused into the patient. Again, very similar process to what I just described. And we're delivering this package, and it's going into the liver where it's unpacked into the cells. And all of this is being delivered into the cells. And these nucleases are acting almost like a pair of scissors, where they're cutting out a piece of DNA, where they're making cuts and they're inserting this new copy in there. So I want to point out, and I've been asked to point out, that this is occurring at a different place. So it's not occurring where the gene, the hemophilia gene is. It's being put into a different place. And I also want to point out that this is occurring not in your reproductive cells. So whenever I talk about gene editing or even gene therapy, one of the questions that I often get from patients, from family members, from people in the community is, if I have gene therapy, what does this mean? Does it mean I'm going to be cured? And the answer is no. It's not a cure. We don't know how long gene therapy is going to last. It may not result in a complete, and from what we know from the studies, it's not going to be a cure, but it will increase your levels, but it's not going to be a cure. We can't say how long the gene that has been delivered will last. And certainly what we know is it's not going into your reproductive cells. So this is not going into your germline cells. So you are not going to, when you have a child, the gene therapy is not going to be passed on to your child. Your child will still have your DNA. So I hope that that's clear. And if you have any questions on this, certainly we can talk more about this in the question and answer session on Friday. Can I have the next slide, please? So current landscape, and I know there's a lot of information, but I also know we're coming up on 9 o'clock. Current landscape for gene therapy. So this is hemophilia A, and I want to point out here on this slide, there's a number of different therapies that are in clinical trials. And one of the things that I want to point out is the stage of the clinical trials. So you heard from our earlier speakers, they went through the different phases. So phase 3 versus phase 1 and phase 2. And you'll note on this slide, there's a number of products here that are in phase 3 and that are currently waiting approval. So what does this mean? It means that gene therapies, they're right around the corner. We are going to see these coming, and that there's going to be multiple choices. Importantly, there's also things in earlier stages. Can I have the next slide? Can I have the next slide? Okay. Also for hemophilia B, again, very similar. You're seeing a number of different therapies for phase 3 as well as for phase 1. Can I have the next slide? We're at 9, so I'm going to go through this a little faster than I had intended. But I also wanted to add that there's a number of things that are in preclinical studies and also that are happening in earlier stages. And so why do I want to make this point? So as a scientist, we're changing so quickly. There's still so much that can happen with gene therapy. There's so many different technologies that are being brought to the market. Things like looking at how to change the cassettes, how we're looking at the expression, how we're looking at the delivery, how we're looking at the immunogenicity, looking at removing cells from the body, doing gene therapy, and then bringing those cells back in. So we really are in the scientific revolution, and there's going to be so many more things that are coming, and we're going to continue to see advances in gene therapy, as well as across the board in a number of different therapies. So as a scientist, it's incredibly exciting to be watching this, and as a mother with a child of hemophilia, it's also exciting. So I think you're going to continue to see advances in gene therapy over the next 5 to 10 years. Can I have the next slide? And again, just a few more examples of some preclinical studies. And we're not going to have time to go through these tonight. We can take some of these in the question and answer session on Friday. Again, that we ran out of time tonight, but just another few examples. And why don't we go ahead and go to the next slide? Again, so sorry we did run out of time tonight. Let me hand the mic back over to close out this session. I do want to thank all of our speakers and also our audience tonight for sticking with us.
Thank you all so much. My I am afraid to start my video because my internet is already down. I apologize. I'm going to lose the slide. Here are a couple of resources that you guys can check out for more information. I want to let you know that our Learning Central has animations that will show you both how the clotting cascade works and also how some of these rebalancing therapies and gene therapies and stuff, how they work. So you might want to check out hfalearning.org and watch those animations before Friday night in case it makes you come up with your questions. And then just a quick reminder that Friday night at 8 p.m. Eastern time, please join us for the On the Horizon question and answer session. If you didn't submit any questions tonight, that's fine. We're going to open it up to questions when we get in there on Friday. So, and that session will also be simulcast in Spanish. So thank you so much. And I hope everyone enjoys the rest of the symposium. I can't wait till we're all in person again, and we'll talk soon.